Tonight I'd like to present to you on head and neck lumps in adults and children. This will be the first time I'm giving a webinar like this, and so I'd encourage you to ask questions as we go, and Rory will relate them to me and we can answer them as we go. I can't see you, but I know you can see me, so I can't gauge you, so I can't gauge your engagement by looking. So please, if you have any questions, feel free to ask, and we can answer them as we go along. When I was training, my GP colleagues frequently would come to me and say someone had presented through their rooms with a lump in their neck, asking what the cause of that may be. And I realized that it can sometimes be very alarming for patients to present with that kind of a diagnosis, and to give them advice, investigate, and then manage them. Tonight's objectives are to explore the relevant patient history when a patient presents with a neck lump, to establish a differential diagnosis in adults with a neck lump, to establish a differential diagnosis in children with a neck lump, and then to engage the appropriate examination and investigations in order to come to a diagnosis, and then when and how to refer appropriately. I like to classify neck lumps into three broad groups: congenital, inflammatory, and neoplastic. You'll be familiar with all of these diagnoses. The most common congenital neck lumps include thyroglossal duct cysts and branchial cysts, both of which we'll touch on tonight. The most common inflammatory diagnoses include reactive lymph nodes and cervical abscesses. And then the neoplastic diagnoses include lymphoma, squamous cell carcinoma, melanoma, thyroid cancer, and salivary malignancies. One of the most relevant things to explore with the patient is the timing of the appearance of the lump. Inflammatory masses come on quite quickly, and they can be quite tender and associated with what is usually an obvious point, a source point, whether it's in the oropharynx or on the skin in the head and neck. Constitutional symptoms such as fever, sweats, and weight loss, or fever and sweats at least, are usually associated with an infection of some description, and weight loss can be associated with malignancy or chronic infections such as tuberculosis. Risk factors are important to explore with the patient. A lump in the neck in an adult patient can be due to metastasis from a skin cancer, which we will explore, and risk factors such as UV exposure in the sun or with tanning lamps is relevant. Smoking is also relevant. Neck lumps can be as a result of metastases from an oropharyngeal cancer. Smoking puts people at risk at that. And also having had a preceding lesion. So for example, if a patient had a squamous cell carcinoma or melanoma removed and then presented later with a neck lump, that may represent a metastasis which has occurred down the track. When a patient presents with a neck lump, examination is very important. So you examine the lump of interest and you characterize it, and then look for cervical lymphadenopathy. Typically, infections and malignancies will present with cervical lymphadenopathy, and they can be usually differentiated based on tenderness, except in the case of chronic lymphadenopathy from tuberculous infections, which we will touch on. Looking for a primary lesion is important. So looking on the head and neck, as well as on the scalp. Looking on the scalp for someone like me is no problem at all, but looking on the scalp in someone with a full head of hair can take some doing. And often I ask patients if when brushing their hairbrush catches on something, or if there's some bleeding that they notice. Also important is to check their oral cavity for mucosal lesions. Neck lumps can present as metastases from oropharyngeal squamous cell carcinoma. This is a diagram of the anatomy of the neck. To the left of screen, showing the lateral neck and what you may find in those areas. So, for example, in the posterior cervical triangle, most neck lumps as a consequence of enlarged lymph nodes, whereas in the midline there are three diagnoses that can occur, which we'll touch on: thyroglossal duct cysts, enlarged submental lymph nodes, and dermoid cysts. Thyroid lumps usually present lower down in the neck, and then in the anterior triangle, enlarged lymph nodes can present, as well as branchial cysts and plunging ranulars. Broadly, the investigations of choice in the first instance include an ultrasound, and then sometimes a CT scan and a biopsy, and we'll touch on that for all of the neck lumps that we described. Fine needle aspiration biopsy is one of the most useful investigations for a neck lump, and they can really lead you in the right direction. All of these diagnoses are relevant, and some of them will require further investigation, but in terms of a first biopsy, a fine needle aspiration biopsy is a great starting point. That may need to be followed by an incisional or an excisional biopsy. For example, if you diagnose a lymphoma, often an excisional biopsy is required in order to characterize it through flow cytometry, which will help the hematologist to direct therapy. Melanoma is a special case because a sentinel lymph node biopsy is sometimes required for primary melanoma. If a melanoma does occur as a lymph node metastasis, you may find the primary and then need to do an incisional or an excisional biopsy to diagnose the skin primary. Now, that was the introduction, so I'd like to move to the next section of the talk, and that is neck lumps in adults. Neck lumps in adults are very relevant because 80% of them are malignant. And if you remember one thing from this talk tonight, and some of you may have heard part of this talk before, it's important to remember that if an adult presents with a neck lump, it is a malignancy until proven otherwise. This is a typical presentation. An older patient with a submandibular lump. It came on over 2 or 3 months, is painless, there are no skin changes over the top of it, and there are no constitutional symptoms. The first differential diagnosis in Australia, the most common cause of a neck lump would be squamous cell carcinoma of skin. If the patient gives a history of variable growth, they can come on quite quickly or quite slowly, depending on the patient's other comorbidities or the differentiation of the tumour. If the patient gives a good history of UV exposure, then it may be a squamous cell carcinoma, and a careful examination of the head and neck may help you come up with the primary. Having said that, somewhere between 20 and 30% of squamous cell carcinoma metastases have no discoverable primary. On the left-hand side is a picture of a gentleman who presented to me with a neck lump, and on examination we found some changes in his lower lip, which we biopsied. It was by no means obvious that he had a squamous cell carcinoma of the lower lip, but he did. A more obvious presentation is to the right of screen, which is a 65-year-old farmer from Condobolin who presented with an obvious squamous cell carcinoma in the left preauricular region, and we will revisit his case later. The imaging of choice for a neck lump in the case of squamous cell carcinoma is an ultrasound and then a CT scan. If you do diagnose squamous cell carcinoma, it's important to scan the head and neck to look for the lump, as well as scanning the chest to look for distant metastases. The biopsy of choice for the lump itself would be a fine needle aspiration biopsy, but for the primary lesion would be an incisional biopsy, or if you can excise the lesion, an excisional biopsy. Definitive excision of squamous cell carcinoma is not something I'll go into in too much detail. Suffice to say that there are high risk lesions and low risk lesions, and their excision depends on the risk of the lesion. The second differential diagnosis would be squamous cell carcinoma of the oral cavity. The patient presents with a usually slow-growing neck lump. If you examine the oral cavity and find this kind of a lesion on the tongue, it's usually painless unless it's very infiltrative, in which case it can be painful. They can be exophytic or endophytic on examination. And if you find one neck lump, you may find more neck lumps. Unfortunately, these tumours can metastasize early and quickly, and you may find bilateral cervical lymphadenopathy. The best way to investigate these is with ultrasound of the neck to define the neck lump, and then a CT scan of the neck and the chest, and then a biopsy. A fine needle aspiration biopsy will get the diagnosis of a metastatic squamous cell carcinoma, and then further investigations will be required prior to definitive management. Melanoma can present as a neck lump. Sometimes, if the patient gives a history of a new pigmented lesion in the head and neck, and prior UV exposure in a patient with other risk factors such as Fitzpatrick type 1 or 2 skin, freckling, red hair, blue eyes, then a melanoma might be the cause. If a new pigmented lesion is found, then it should be an incisional biopsy or an excisional biopsy should be done. Examination of the head and neck, if it reveals that the pigmented lesion, the principles of A, B, C, D, and E, that's asymmetry, borders, color variation, diameter greater than 6 millimeters, and evolution of the lesion will help you to diagnose a melanoma. Imaging of choice includes an ultrasound of the neck and then a CT. An incisional or an excisional biopsy is required if you can find the primary melanoma. It is important not to take bigger than 2 or 3 millimeters if you're going to do an excisional biopsy, because if the Breslow thickness is over 0.8 millimeters, we may need to do a sentinel lymph node biopsy. I'll explore sentinel lymph node biopsy and melanoma in more detail in the lecture that I'll be giving in, I think it's on the 13th of May. A fine needle aspiration biopsy is all that you need to diagnose melanoma, a metastatic melanoma in the head and neck. If a patient presents with a lower neck lesion, they can appear suddenly, but usually they can have been are there for quite some time. And often thyroid cancers are discovered incidentally when a patient has an ultrasound of the neck for another reason. Some patients, the minority of them, have a family history of thyroid cancer, and that's relevant particularly in children, where medullary and papillary thyroid cancers can be hereditary. Examination of the thyroid itself may reveal the lump. Sometimes the patient is able to feel it better, or often the patient is able to feel it better than we can, and they can help to direct the examination in order that you can find the thyroid lump. Some people with thyroid cancer will present with a lateral neck lump representing metastatic thyroid cancer, and that can be defined by ultrasound. The ultrasound will give what's known as a TIRAD score. The TIRAD score from 1 through to 5 will help to ascertain whether or not, at least radiologically, the lump is possibly malignant, and that can be confirmed with a fine needle aspiration biopsy. Salivary gland malignancies tend to present most commonly in the parotid gland. Some people do present with submandibular tumours, but 90% of them are parotid. They have a variable growth pattern depending on the differentiation. They're usually painless, but if they are a malignancy and they affect the cutaneous nerves of the ear, the patient can present with ear pain or trismus. When you examine the patient, look for the lump in the parotid gland. Look for a submandibular lump, and then sometimes the patient will have cervical lymphadenopathy. Again, the imaging of choice is ultrasound and then CT, and biopsy of choice is a fine needle aspiration biopsy. An MRI is important in the definition of a parotid mass because we like to define this relationship to the facial nerve. 90% of parotid masses affect the superficial lobe, but about 10% of them affect the deep lobe, and an MRI helps to define the anatomy in order to direct the surgery. If a patient presents with a neck lump, they may not have what is a local cancer which is metastasized to their neck. It is important to examine the other lymph node groups on the other side of the neck, the axilla and the groin, and you may find that the patient has a lymph node elsewhere If you question them further, if they have B symptoms, which include fever, night sweats, and weight loss, or if they appear generally unwell, and on examination of the abdomen, if you find hepatosplenomegaly, the patient may have lymphoma. The imaging of choice in this case is an ultrasound or a CT scan, and then once the fine needle aspiration biopsy defines the lymphoma, the patient usually needs to go on to have a core biopsy or an excisional biopsy in order to further type the lymphoma to direct the hematologist to treatment. So after you've diagnosed the patient on your history, your examination, your imaging and the fine needle aspiration biopsy usually, what are the next steps? The next steps in most cases are to go on and do a pan CT or a PET scan in order to define whether or not the patient has distant metastases. By virtue of the fact that they have a neck lump, they probably have regional disease. If they have distant disease on PET scan, it directs the management in a slightly different direction. A patient with loco-regional cancer is usually treated with a combination of chemotherapy, radiotherapy, and operative therapy with a view to cure. A patient with widespread metastases, with the exception of lymphoma, is treated usually with palliative intent. So I'm going to run you through a case study here. If you remember our farmer from Condobolin, he presented, he was referred by a colleague of mine from Orange with a recurrent left preauricular squamous cell carcinoma, which on biopsy was poorly differentiated. He went on to have a CT scan which showed that he had a metastasis in the neck, and he then went on to have a PET scan which showed no evidence of distant disease. He had a past medical history of chronic renal failure from IgA nephropathy and a failed transplant. So he was immunocompromised. The risk factors, this is a high-risk squamous cell carcinoma in that it's recurrent and that the patient is immunocompromised and the lesion itself is poorly differentiated. As you can see here on the right of screen, there's a white arrow pointing to a submandibular lymph node representing the lymph node metastasis in his neck. We discussed him at the multidisciplinary team meeting and decided that he should have operative management, which included resection of the lesion, re-resection of the lesion, a superficial parotidectomy, and level 2 and 3 neck dissection with reconstruction, followed by radiation therapy. If you notice the lesion on the left preauricular area, I've marked the margins of the lesion with a dotted purple dots, and then the solid purple line around the lesion is the surgical margin. The line drawn as a J down into the patient's chest is how we will shift skin up onto his preauricular area in order to do the reconstruction. For those who are squeamish, now is a good time to look away because I'm going to show you an operative photograph. This is the operative. Sorry. This is the resection photograph, and in it you can. I'll just orientate you. It's the same orientation as the slide with the marking, and as you can see, here's the patient's ear. We're retracting the sternocleidomastoid. This is the jugular vein, and the lymph nodes in level 2 and 3 of the neck have been resected. What you can see here is the facial nerve with the zygomatic branches, the buccal branches, and the marginal mandibular branch you can just make out going down here. This is the zygoma, and the temporal fascia needed to be taken in order to clear the tumour. The cartilage on the anterior cartilage on the external auditory meatus also needed to be resected in order to clear the tumour. We've got clear. This line here is the line of the reflected skin flap, which is reflected anteriorly. Thankfully, we've got clear margins, and then with the help of a colleague, we reconstructed him. He spent a week in hospital and he did very well. He'll go on to have radiation therapy in orange. At this point, I'd just like to take a break and ask if there are any questions about head and neck lumps in adults before we move on to the paediatric part of the lecture.
Hi, Gideon. So we do have a few. Can you hear me?
Yes, I can.
Great. So the first one is, can GPs organise ultrasound-guided biopsies for the lumps prior to referring?
Yes, they can. And when they do, it's really helpful to us in terms of moving forward with the patient's management.
The next question is, can reactive lymph nodes be left alone?
Reactive lymph nodes is something that happens quite frequently in children, and it becomes a tug of war between you as the doctor and the parent as to how long how long everybody's prepared to leave it alone. In adults, don't assume it's a reactive lymph node. In a child, actually, reactive lymph nodes are extremely common, and I think everybody in the audience will have had a situation where they've had a child with a reactive lymph node. It's obvious to them it was reactive, and they haven't wanted to pursue it further, but the parents are anxious. And what I usually do is reassure the parents and continue to reassure them as long as you're confident it's reactive. And then at some point, you have to make a decision as to whether or not to remove it. And the indications to remove it are basically to restore family harmony. Almost in every single case I've thought it was a reactive lymph node, I've ultimately succumbed to removing the lymph node in order to settle the parent and the family down so they can get on with their life. It's a short operation, it's low risk, and it helps them to get closure and then move on. Having said that, it's not indicated at the first, second, or third visit. It's something that really, if you see that it's causing problems, then sure, send them and have it resected. But otherwise, just continual reassurance until essentially you lose the debate with the parent.
Right. The next question is there a chance of metastasis with FNAB for melanoma?
No. No, it's a good question, but the answer is no.
The next question is, can a patient with dental implants and a parotid mass do an MRI?
They can. Can I just go back to the question that you on melanoma? One of the things about melanoma and seeding is, yes, it is possible to seed in particular circumstances. So transcoelomic. So if you do a biopsy across the abdominal cavity with a core biopsy across the abdominal cavity, and you traverse the peritoneal cavity, or same thing in the chest cavity, you can seed those cavities. But where there's no body cavity involved, there's no evidence that a metastasis can occur. And metastatic melanoma is a changing field, and on the 13th of May, I'll discuss that in detail. With the advent of immunotherapy, things are very different in melanoma. And just moving on to the next question, can you do an MRI in a patient with amalgam fillings? You can, but it's just something you need to discuss with the radiologist. They can modify the MRI protocol to accommodate for that pretty well. The MRI in parotid lesions is I guess it's something which is really useful in terms of anatomical mapping. But in patients who have metal implants which precludes them from having an MRI, a high resolution CT scan is almost as good.
Great. And the last question we have is, why remove rather than an FNAB?
Why remove?
They haven't referred specifically what they were referring to.
Presuming it's a reactive lymph node. So if in an adult, you can definitely do an FNAB if you believe it's a reactive lymph node. In children, particularly young children, FNABs need to be done under general anaesthetic because most young children won't sit still to have an FNAB. There are facilities in the children's hospitals to do FNAB under general anaesthetic, but the private radiology practices, for the most part, don't have the facility for general anaesthetic in children.
Great, thanks. So that's all the questions we have for now, but everyone keep asking your questions in the question tab, and next time we have time for questions, we'll ask them.
Okay, right, so we're just going to move on to the next part of the lecture, which is paediatric neck lumps. Paediatric neck lumps, in terms of epidemiology, are the exact opposite to adult neck lumps. 80% of them are benign, and most of them are either congenital or inflammatory. As patients get older, the chances of them having a malignant neck lump increases, but you can safely assume that the vast majority of neck lumps in children are benign, with some notable exceptions, and we'll get into that. This is a neck lump which will be familiar to many of you. It's a patient that presents with a midline neck lump, which has been present for some time, usually months, potentially years, and it may or may not have become infected or discharged pus. And this is a thyroglossal duct cyst. This is a photograph of a thyroglossal duct cyst. These occur because the thyroid forms at the foramen cecum between the anterior 2/3 and the posterior 1/3 of the tongue, and then it descends in utero, in embryonic life, through the hyoid bone, and then in front of the thyroid cartilage to come to lie in front of the second, third, and fourth tracheal rings in the lower part of the neck. And it can leave bits of thyroid behind on its descent, which can form cysts. The differential diagnosis for this is a dermoid cyst or an inflamed lymph node. Most of the ones I've seen in the midline have either been dermoid cysts or thyroglossal duct cysts. Differential diagnosis can be achieved on tongue, or is said to be able to be achieved on tongue protrusion. So if you get the patient to open their mouth and protrude their tongue, thyroglossal duct cysts are supposed to rise because they're attached to the hyoid, whereas dermoid cysts will stay in place. In practice, I haven't really seen that to be the case, and for the most part, I've treated midline neck lumps as if they were thyroglossal duct cysts. The best way to image these is with an ultrasound or an MRI. In a child, a presentation like this, a biopsy is not required, and a clinical and radiological diagnosis is all that is required. I don't usually do MRIs for thyroglossal duct cysts unless they're recurrent. So I have a patient currently who has a recurrent thyroglossal duct cyst. When they present infected or if they're discharged, the recurrence rate after operation approaches 50%, and sometimes an MRI is required in that case. A lateral neck lump has a slightly different differential diagnosis. If it's been present for weeks or months, it may represent a lymph node. If it's been present for months or years, it may represent a branchial cleft cyst. Children, it is important to remember that though 80% of neck lumps in children are benign, 20% of them are malignant. So it is important, particularly in older children, to examine their skin, examine their oral cavity, and examine the other cervical lymph nodes. The imaging of choice again is an ultrasound in the first instance. CT scan is kept in reserve. In teenage patients, sometimes when they present with cervical lymphadenopathy, it's lymphoma. Lymphoma is the most common malignancy of the head and neck in children, and if that is suspected, a fine needle aspiration biopsy may be indicated. In a teenage patient, most of them will be able to handle a fine needle aspiration biopsy without an anaesthetic. If it's a cystic mass, it may represent a branchial cleft cyst. As you can see in the diagram, a branchial cleft cyst sits sort of points just anterior to the anterior border of the sternocleidomastoid, and if there's a tract associated with it, it can go superiorly to the tonsillar fossa. It isn't usually visible intraorally, and then if the inferior tract will usually exit at the base of the neck. But most of these don't have tracts, they just present as cysts. In babies, Sometimes neck lumps are noted on antenatal scans, and sometimes they appear postnatally. This is a child on the right of screen who presented with a posterior occipital neck mass. There's no evidence of inflammation. It was painless, and it was very soft and fluctuant on palpation, and on transillumination, it lit up brilliantly. Examination of the mass is important, and also cervical lymph nodes. Babies do get neck lumps which are malignant, but it's very rare. We'll touch on that in a minute. The investigations of choice here would be ultrasound in the first instance. CT scan is usually not required. If there's any equivocation on the ultrasound, the next step would be an MRI. In this child's case, he had a lymphatic malformation, and so that's able to be diagnosed on ultrasound and/or MRI by a pediatric radiologist. There's no real need for a biopsy. We don't treat them operatively. We treat them with sclerotherapy, and he went on to have sclerotherapy. The lesion shriveled up, and he did very well. This is a really classic presentation. Atypical mycobacterial infections in the cervicofacial region of children. It usually presents in toddlers. The most common area for it to present is in the submandibular area. The second most common is in the parotid node in the preauricular area. The patient will present with weeks to months of discoloration, weeks to months of a lump, which then may become discolored. Sometimes they discharge spontaneously, but the hallmark signs are they're painless. There are no constitutional symptoms, and the skin goes a purplish color once they start to mature. Imaging can be done with an ultrasound, but usually this is a clinical diagnosis. If a patient presented with these clinical signs, I'd be satisfied to make a diagnosis of atypical mycobacterial infection. The best treatment is operative with a short general anaesthetic and a curette of the affected lymph node. The lymph node is usually necrotic. It needs to be curetted out, and the patient will heal up over a couple of weeks. Sometimes they require adjuvant antibiotic therapy with azithromycin and a number of other antibiotics, but using them as definitive management has about a 50% failure rate. Having said that, they can be used as adjuvant management, and your paediatric infectious diseases consultant can help you with that. Unfortunately, not all head and neck lumps in children are congenital inflammatory, and in this case, the patient presented with a neck lump which was a benign tumour. He's presented with a slowly growing painless mass. On examination, it was non-tender, but it was very, very hard. The ultrasound didn't really yield very much, so we did an MRI, and it showed, I'll show you what the picture looks like in a moment, but we did a core biopsy and it was diagnosed as a desmoid tumour. On your left of screen, you can see an MRI in the coronal and in the axial plane of the patient when they were 6 years old. And that big white blotch on the right-hand side is the desmoid tumour. It's submandibular and wraps around the posterior aspect of the mandible as well. And it's quite large, as you can appreciate it would have been clinically. In order to resect this, we would have had to have done a hemimandibulectomy, which is an incredibly morbid thing to do in a child. And so we elected to treat him non-operatively with vinblastine and methotrexate, and the lesion shrunk down so that on the right of screen you can see how he was mid-therapy at 7 years old. The lesion has shrunk down considerably, and then on an MRI done about 3 months after that, the lesion was barely noticeable. Desmoid is a difficult area. We don't know why some of them respond to chemotherapy and some of them don't. The resections can be really quite challenging, particularly in the head and neck. And we try and rely as much as we can on non-operative therapy in order to preserve the quality of life of the patient. Having said that, we have had to resect some. Some of them have been successful and others, unfortunately, not. This patient's done very well. Right, so head and neck malignancies in children, it is really important to remember that these are very rare, very, very rare. The most common is lymphoma, which typically happens in older children or teenagers. This is followed by thyroid cancer, usually in older children or teenagers. And thyroid cancer can be associated with can be associated with a family history if they have a genetic predisposition to thyroid cancer. As an aside, if you happen to have done an ultrasound of the thyroid in a child and you find a thyroid lump, unlike adults, children, if a lump is found in a child in the thyroid, it needs to be investigated thoroughly. About somewhere between 1/4 and 1/2 of all adults will have some sort of a thyroid lump or cyst, and almost all of them are benign. In a child, if you find a lump in their thyroid, 25% of them are malignant. Sarcoma is the next most common. Depending on the age of the patient, they can be bony or soft tissue in nature. Neural malignancies tend to happen in much younger children, around sort of 6 months to 1 to 2 years old. The more common of those two are neuroblastoma and retinoblastoma. Melanoma is very rare in prepubescent children, but is increasingly common in adolescents. A germ cell tumor tends to happen in younger children, and carcinoma in children is exceedingly rare. This is a story of a little girl who presented with a right-sided parotid mass. It had grown over the preceding 2 or 3 months. It was associated with some cervical lymphadenopathy. We did an ultrasound and found the mass in the right parotid, in the right masseter, which is the muscle underlying the parotid. We went on and did an MRI to define the lesion more closely, and I'll show you the picture of that. And then we went on and did a fine needle aspiration biopsy followed by a core biopsy and diagnosed her with rhabdomyosarcoma. Fortunately, it had not spread anywhere, and the cervical lymphadenopathy ended up being reactive. So she had a localized rhabdomyosarcoma. Rhabdomyosarcoma can be broadly divided into 2 different types. One is embryonal, the other one's alveolar. She had embryonal type, which is a far, far better prognosis. So she went on and had neoadjuvant chemotherapy. So you can see to the left of screen was the initial, what the initial scan looked like. So that's quite a large tumor. And then after neoadjuvant chemotherapy, the lesion shrank down to a definitely resectable size. So we took her to theatre, and for those who don't like operative photographs, now's the time to look away. This is the operative photograph. You can see the facial nerve. I'll just get my pointer back. You can see the facial nerve, the buccal branches of the facial nerve here and here. There's one above and one below this structure here, which is the salivary duct of her parotid gland. We've removed the masseter muscle beneath it, and that white structure that you can see is her mandible. That resection fortunately was complete, and she went on to have adjuvant chemotherapy. The benefit of resecting it with clear margins means that the radiation therapy she got post-operatively was diminished in its magnitude, which diminishes the prospect of her having hemifacial hypoplasia. And she's done very well, and so she'll be in a close follow-up program. And most children who present like this, who go on to have this kind of resection, are cured. So at this point, I'd just like to pause and ask if there are any questions about head and neck lumps in children.
Yes, there's a few questions that have come through. Firstly, do branchial cysts need surgery?
Yes, they do. It's not urgent, but they do need to be resected. Ultimately, they usually cause a cosmetic problem in that patients don't like having a mass poking out past the anterior aspect of their sternocleidomastoid in the anterior triangle of the neck, and also there is a risk that they'll get infected. So yeah, it is best to resect them if possible. The other thing is just to mention, sometimes branchial cysts present in older patients, so not just children, but patients in their 20s, 30s, and even 40s. And there have been occasions where we have thought we're dealing with a branchial cyst. We've biopsied it, come back with atypical squamous cells, thought it was a branchial cyst, resected the cyst, and found that it was a cystic squamous cell carcinoma metastasis. So they should be referred and worked up thoroughly and then resected.
Okay, so next is, how is atypical mycobacterial infection treated? Does it need anti-TB therapy?
Some of the drugs that are used are anti-TB therapy. There's a whole list of drugs that can be used. Azithromycin and rifampicin are two of the more common ones. And they are drugs that, rifampicin particularly is one that is used for tuberculosis. The other drugs for tuberculosis we don't tend to use for things like isoniazid. I don't tend to be used for it. In the first instance, there are 4 ways to treat atypical mycobacterial infection, or 5 ways. Or 6 ways actually. There's non-operative, so you can give antibiotics only, and that has about a 50% success rate. You can do surgery, and the surgical procedures that are available are an excision of the node, incision and curettage of the node, aspiration of the node, and just incision and drainage. Of those, excision has the highest success rate, but it also puts the patient at risk of damage to one of the branches of the facial nerve. So incision and curettage is the best balance between risk and benefit, in that it has a high success rate of around 90% and has a very low rate of facial nerve damage. The other way to treat it is just to leave it alone, in which case it will point to the skin and discharge, and the discharging sinus will take about 9 months to heal. And how you treat atypical mycobacterial infection is very much a discussion with the parent and their preference. My preferred method of treatment is incision and curettage, and then antibiotic therapy in concert with an infectious diseases consultant.
Okay, the next question is, would radiotherapy help in a desmoid tumor?
That's a controversial area. We don't really know is the answer. A third of desmoid tumors will improve on their own, a third of them will stay stable, and a third of them will get better. We don't know why some desmoids respond to chemotherapy or radiotherapy. There is a whole list of ways that we've tried to treat desmoids, and the best conclusion I can come to from having scoured the literature is that we actually don't know what we're doing with it. My rule of thumb is, if the desmoid is resectable with a clear margin, then I'll resect it. But if the desmoid is not resectable with a clear margin, or if the desmoid is resectable with a higher level of morbidity to the patient, I will try and treat it non-operatively. So either with chemotherapy in a child, or sometimes with radiation therapy. Usually radiation therapy is reserved for a recurrent desmoid, or an inoperable desmoid, or multifocal desmoid in adults. We try to avoid radiotherapy as much as we can in children because it causes growth. It causes problems with growth.
Okay, so the next question is, how do you manage periauricular pits in kids?
So preauricular pits in kids are really common, particularly amongst Southeast Asian children. If they're so it's important to say, if they've never been infected, then they're not pathological, in that you don't need to remove them. If they've been infected, then they should be removed, because if they've been infected, then they will probably become infected again. The exception to that is if the patient has bilateral preauricular pits. If that's the case, then the patient should have a renal ultrasound to make sure that they don't have any urogenital anomalies, which can be associated with a rare syndrome where a patient will have bilateral preauricular pits and some sort of renal anomaly. But with the local disease, like the pit itself, if it's never been infected or it doesn't cause a patient any problem, there's no indication for operation except a cosmetic one.
Okay, great. The next question is, could you comment on HPV as a cause of neck cancer, especially in young, non-smoking and non-drinking adults? Yep,
so HPV-related oropharyngeal cancer is on the rise in young adults. It tends to be a lower risk cancer, although we have had some problematic cases, particularly in the unit where I work. Generally speaking, the degree of operative intervention that we are now offering in these patients is less and less aggressive, and we're treating them more and more with chemotherapy and radiotherapy, which is less morbid than the operative alternative. What we're sort of hoping to see is a decrease in the rate of these kinds of cancers as patients who are having the Gardasil vaccination start to grow up.
Okay, and the last question we have here is, what is the next step in thyroid FNAB demonstrating atypical cells of unclear significance?
Yes, so that atypical cells of unclear significance fall into, so then you're talking about the Bethesda categorization of fine needle aspiration biopsy. That would fall into Bethesda category 3, and it depends on whether you are dealing with an adult patient or a pediatric patient. I'll deal with an adult patient first. So if it's a Bethesda category 3, then the patient should have a repeat biopsy. The exceptions to that are if the patient has an obviously enlarging lump or has cervical lymph node metastases, obvious cervical lymph node metastases, or a lesion which has a high thyroid score on ultrasound. In that case, a diagnostic hemithyroidectomy is sometimes indicated. But as a general rule, Bethesda category 3 lesion should be rebiopsied in an adult. In a child, a Bethesda category 3 is a different situation. Because of the higher rate of malignancy in children, that is enough to actually do a diagnostic hemithyroidectomy from the get-go.
Great, so that's all the questions we have so far.
Okay, thank you. So we've explored a number of different types of head and neck lumps in adults and children, what the relevant patient history is for all of those lumps, some of the differential diagnoses in adults, and I'll reiterate at this point that 80% of neck lumps in adults are malignant. What the differential diagnosis in children is, and I'd reiterate at this point that 80% of neck lumps in children are benign, what the appropriate examination is and the investigations are, and when and how to refer. I'm available to everybody in the audience for advice, either by email or over the telephone. Please feel free to email me or call me either at my practice or on my mobile if you have questions. If there are patients that you would like to refer, my contact details for referrals are on the slide. I'd just like to thank Rory again for inviting me to present tonight. I'd like to invite everybody present to attend the melanoma and sarcoma session on the 13th of May. And I'd just like to thank you all for taking time out of your evening with your families to attend, and have a good evening. Stay safe.